of all, welcome Liz Woodiston from NHS England. Liz, right? Well done. Thank you for coming. She's our officer from NHS England, so I hope you find this useful. Well, help. Right, so we've got, of course, remind you that we are being live streamed today, so please give your name and organisation before you speak, and make sure you sign in so we know you've been here. Apologies, can you write those on the sheet? No, at this stage, no particular announcements. So, minutes of the meeting on the 24th of February. Read those. And then we move on to Chief Officer Report, John.
Morning, everybody. So I'm going to take the report itself as read and just bring you up to date with a couple of other items. So the first is that you will have seen from the national news today that NHS England, with the other 5-year forward view partner national organisations, has published a next steps report in terms of trying to map out what the progress of the NHS is going to be over the next few years. Again, you can read that at your leisure, but I do want to just pull out this announcement that there are going to be 9 new accountable care systems in England, which are basically sustainability and transformation plan areas. And we were asked how Greater Manchester wanted to be described and to associate itself with these systems. And what we've basically said, and what NHS England have published, is that we are already a operational accountable care system under devolution. And therefore we will join the network of these ACSs and share our experience and learn from them. But we've also made clear, and it has been accepted, that being part of that network does not fetter our discretion as a devolved area in terms of the choices we're making around the way that we use resources and the programmes that we pursue. I think then I want to just focus on performance as we reach the end of the year. Today I will do a full performance report for you with Nikki O'Connor, our Chief Operating Officer, in the next couple of years, next couple of months, that will summarise our end of year performance. But there have been a couple of issues that have vexed us over the winter that are worth just quickly sharing. So one of those is delayed transfers of care, where we have been an outlier in terms of the regional and national position. And I'm pleased to say that due to huge efforts across the whole of Greater Manchester, we've now managed to reduce those delays down to a level well below 4% at the end of March, which doesn't quite meet our target trajectory of 3.3, but is very close and is a massive improvement on where we were even 6 weeks ago. So I want to recognise all the work that's gone into that, but also to make clear that it is only a moment in time, and what matters now is the sustainability of the system and the use of the new social care resources in particular to ensure that we maintain a flow of patients and liberate hospital beds and make sure that discharges happen in a timely way. We've also, of course, been focused on urgent emergency care performance more generally, and particularly the route back towards the 95% target. And we've set a programme of working with most of our systems, which we call back to the 90s. So let's get ourselves over 90% first. And therefore I want to really commend UHSM and CMFT, South Manchester and Central Manchester, for the fact that consistently through March they have met at least the 90% target, and indeed UHSM have consistently been above 95 and as high as 99 on a whole number of days. This is a tremendous achievement, and I just want to recognise the work that has gone into that. And we will of course be wanting to glean the best practice in terms of the rest of our system. And then final piece of good news is on our cancer performance, and particularly the key target of the 62-day standard, where we were the only place in the whole of England that met that standard in January. And again, I want to commend everybody who was involved in that, but particularly the directors of operations who worked tirelessly to try to ensure we maintain our record of GM not having missed that standard since 2011. This is not usual in terms of the rest of the country, and it is a great team effort that has enabled us to meet that performance point, it won't get any easier going forward. So that's what I want to say by way of introduction, and of course happy to take any questions.
Okay, that's John. Tony?
Thanks, Peter. Actually, I've given John notice of something I wanted to ask. But if I may, John, rather than you mentioned the very credit-worthy performance around cancer treatment, but of course from next year, from spring next year, the plan is to bring the 28-day turnaround for cancer care patients. And whilst that's clearly desirable, it is a very stretching target. I mean, it's probably not fair to ask you to comment too much today, but perhaps on a future occasion, could we have some consideration of what that will mean in practice? So that's what the thing I just wanted to register today is that one of the changes that some people will be aware of, that there's been an amendment to the Mental Health Act, which replaces this responsibility on CCGs and takes away from police responsibility for those who historically would have been taken into police custody. It is important that we have a practical way of making sure this system works. Now, the police on the one hand are worried about this, and probably other people in this room might be worried about what that means in practice. So we need a mechanic to take the conversation forward so that there is a seamless transfer between police responsibilities as of till midnight today and the transfer of responsibilities to CCGs as from tomorrow.
Thanks for that. So on the first question, just to contextualise this for people who got caught up in the news in the last 24 hours, as part of the publication of this new 5-year forward view next steps, the NHS England nationally have signalled some shifts in priority with respect to different standards within the NHS. And what they've basically done is put an additional priority on cancer, and as Tony Lloyd said, in particular the introduction of this 28-day standard, and signalled maybe some relaxation around waiting times for elective care, and particularly the 18-week standard. Now, first of all, we really need to understand what that means. It's a slightly strange situation for Greater Manchester because we consistently meet the 18-week standard, the 92% target, unlike much of the rest of the country. That's something we need to get our head around to start with. And then we've obviously got to consider what it will take in order to meet the 28-day standard once we've got more detail. In terms of mental health, first of all, we should make absolutely clear that we welcome these legislative changes. They're good for people in mental health crisis. It means that they are far more likely to receive the right care and to be taken to the right place of safety where they need to. And of course, readiness is critical for the changes that do come into force on the 1st of April. And so I thought, if it's okay, Chair, through you, I'd like to invite Simon Barber, who leads a lot of our work on children and young people's mental health, to say a few words about our preparedness.
Thank you, John. Yeah, my name's Simon Barber. I'm Chief Executive at 5 Boroughs, and I lead the Children and Young People's Workstream for Mental Health. I think, Tony, the reassurance that I can give you is that the system is well aware of the changes that come into effect, where police officers need to consult with a health professional before applying Section 136. And specifically for children and young people, that police custody can't be used for young people and only in exceptional circumstances for adults. I think to give the reassurance, last year there were 77 occurrences where children were subject to Section 136, and in no case did a child go to custody suite. They always went to a hospital-based place of safety. And for adults, there were 1,300 uses of Section 136 and only 13, so 1%, went into custody. I think Greater Manchester is in a very good position in terms of already behaving in the way that from the 1st of April the rest of the country is expected to behave. There's a high level of preparedness across the system. That's both police and health. That's been facilitated very much by the Crisis Concordat Group under Jim Battle's leadership, released to and beside both of them. I had a good conversation with Andy yesterday, and I think the system in Greater Manchester is very ready for the changes.
Sorry, it's Richard Boots on the quality for the partnership. I just want to come back on the first point around 62-day and then potentially much tighter targets for timeliness. First thing to say, of course, is it always matters to patients how long they wait when they're waiting for diagnosis and treatment of cancer. But for some cancers, it really does matter in terms of the outcomes as well. A really good example of that is lung cancer, where you really need to get your diagnosis and treatment as quickly as possible. So already we've charged the 20 pathway board directors to be looking at the pathway for their particular groups of cancers to say what could we do, what's the art of the possible to accelerate diagnosis and treatment. So that work's already been instigated prior to any announcements today, and that will continue up until the summer.
Okay. Any other questions, comments? No? Thanks, John. Move on to the transformation fund up next, Steve.
Thank you, Chair. So there's no specific bids for approval at the board today, so you'll have received the report. I'll just take you through a bit of a stock take of where we're up to and what we can expect to see coming through in the next couple of months. So we've now got all but 4 localities through the process and are working intensively with the remaining 4 localities. That's the 3 North East sector localities of Bury, Oldham and Hayward, Middleton and Rochdale, and there's an intensive piece of work going on at the moment with those 3 to make sure that the understanding of how those 3 localities work together, particularly in relation to activity and financial flows into Pennine Acute Trust, is absolutely aligned in those 3 bids, and we'd expect those 3 bids to be coming to the May Transformation Fund Oversight Group and onwards to SPB and SPB in June, and the same for Trafford, where again things are starting to come together now. We'd expect their bids to come through on a similar timescale. And what that does is that moves us into more of the thematic type bids that will be coming through after that. And the first significant one of that, on top of the primary care bid that was considered a couple of months ago, is around the significant GM-wide investment in mental health, and particularly help us understand how the GM work on mental health will dovetail with the work in individual localities. So, as I say, no specific things to be approved today. So, there for the board to note.
Okay, thanks, Steve. Any questions, Steve? No? Move on then to Health Innovation Management Report. Delighted that Lorraine's with us to make the presentation.
Thank you, Chair. I'm not sure whether everybody will be able to see the screen behind me. There might be a few quick flecks on this side of the room, and I'm sorry for that. I'm not going to reprise what's in the report because I think that should be reasonably self-explanatory. So these few slides are really just to highlight some key points. And the first of them is in a sense the obvious one. You know, I think when we're all deep in the doing, it is fair to say that Health Innovation Management had a difficult first year. And I think when you're deep in the doing, it's quite hard to remember all the time what the extraordinary opportunity devolution has given to Greater Manchester. I am reminded of it frequently by those who come to see me wanting to be involved and to understand how they can engage with the system, and how Health Innovation Manchester is going to tackle the problems that the world faces in terms of accelerating innovation in health. It's very good to be conscious of that. The platform which that gives us is pivotal to this. The combined governance which allows decisions to be taken and to be implemented with a speed and efficiency that simply has not been possible in the past and would not be possible anywhere else is a key advantage for Greater Manchester. Aligned to that, the process in the second circle, which you can see it on that slide, of integration and consolidation that is going on across Greater Manchester at the moment is also crucially important and enabling for us. It's enabling in the sense that it is creating a genuine place-based end-to-end perspective on health and care needs and health and care priorities. And again, I think important that there is a very strong emerging set of priorities in social care and in population health as well. And we are now talking to social care colleagues about how we Lillian Greer, who is Dean of the Med School and is the academic lead for Health Innovation Manchester, is in the room today, and the power of those assets to drive discovery is a critical advantage for us. And as also are the links that we already have into industry and the power of the devolved authority to attract industry collaborators from across the world. Just one point I want to make on this, actually, but it is critical. This is what we are creating in Health Innovation Management is a system, and it is a system that needs to capture inputs from every part of the translational spectrum. While it is, while we must make progress and drive momentum through early wins and quick implementation, we mustn't neglect the discovery end of that spectrum as well, because it is the work that happens in basic research today that will drive the opportunities for innovation and the discoveries that will transform health and care in the longer term as well. It's all of it joined up end to end. We are in a great place in terms of influencing national and international policy. In the wake of the publication of the industrial strategy, the Office of Life Sciences is now leading a review of life sciences strategy for the UK. We are ideally placed as a system to input to that and to benefit from it. It's highly likely in the course of the summer, probably by early autumn, that there will be proposals for health innovation hubs coming out of that review. We will be ready for it. The Health Innovation Manchester Board has already met and agreed to submit or to prepare a One Manchester bid against whatever that call for proposals looks like when it emerges. Similarly, the Accelerated Access Review report that was published several months ago could almost have been written in this city, and it is so consistent with our direction of travel and what we're doing. And thirdly, the absolute imperative for all health and care systems to get brilliant at managing informatics and the role of digitisation in terms of transforming how health and social care works across the UK is an imperative for us. And getting GM joined up electronically is a crucial role for us. Which takes us to the one slide that I'm going to use to actually just summarise the what it is that we are going to be delivering over the near term. There are three underpinning what we call strategic enabling pieces of work that will drive innovation across much else. The first I've just mentioned, which is informatics, and the need to create informatics platforms that join the system up, that are critical to all of you in terms of taking a citizen-based view of health and care needs, but also critical to us in yielding information which will help us to understand how priorities can be interpreted into opportunities for industry. The second is precision medicine, which is inextricably linked with the work that is being done in informatics within the university in particular, but also with the work of genomics colleagues and other specialist departments within the university. But also contains within it the possibility of some quick wins through pathway change. It's not all about basic science in the lab, but all deliverables that come with that as well. And the third is containing the good work that's already done in relation to clinical trials and research, so that every patient from Greater Manchester gets the opportunity to participate in a trial relevant to their disease. Those are more the long-term strategic stuff. We do need momentum, and we need energy, and we need kind of proof of what we're about relatively early on. So we have started to build up a portfolio, or a pipeline rather, of quick wins. Brilliant stuff that has been done at individual locality level right across Greater Manchester, which has previously not seen the light of day in terms of projects that actually are capable of being fairly quickly brought forward for decisions by the partnerships, joint commissioning, joint provider boards, and being rolled out across Greater Manchester, starting to tackle that huge problem of standardising outcomes. we'll take an agile approach to dealing with that by putting out a series of calls through the year to industry to bring forward proposals in response to identified need that we work through with colleagues. My day job brings me into contact with businesses of every size and scale, and so I know at first hand how confusing they find the healthcare landscape, not just in Greater Manchester, just typical everywhere else. But there is also a lack of clarity about how it works around here, how you get your innovations quickly evaluated, either approved for onward use in trials and pilots or adoption, or refused. So we have developed or built upon an existing innovation pathway in order to support both our partners in the system, but also industry outside in understanding how it works. And we will set ourselves pretty tight milestones in terms of how quickly we respond to innovations that come to us for proposal. And that will feed over time, that will feed really the ability of us to transform ourselves into a health and social care system that thinks innovation and knows where to go to get good ideas taken up. And my final slide is really about how what we have set ourselves to do between now and September. The decision taken by the Health Innovation Manchester Board last year to coordinate or to bring together the disparate organisations that currently sit within the academic health science system and the academic health science network within a single governance structure is crucially important. It will help us to remove overlaps and duplication, to drive synergy and to create clarity for all. We're on with that now. We have a shadow senior management team which has already started to implement the recommendations that were approved in the Health Innovation Manchester Plan. We will spend a lot of time over the next 2 months out on the road. There has been a woeful lack of communication, I think, across GM about what Health Innovation Manchester is for and how it relates and responsive to the needs of Greater Manchester. So we will be seeking places on agendas of key boards in every part of the health and care spectrum over the course of the next 2-3 months. We crucially between now and September, when we will come forward with a revised business plan and a proposal for transformation fund support for 3 years, we will combine doing that setup work with engagement and the implementation of some of those quick wins I talked about earlier, so that we won't lose time in actually starting to make a difference and to generate results that demonstrate the power of the system. So that's all I wanted to say, particularly by way of introduction.
Okay, thanks, Ruin. I think, as you say, it's a really exciting spin-off from devolution. I mean, that's as we went into the... We didn't see this benefit, which will not only improve healthcare even further, but obviously it will create important economic prospects for this region in the future. So well done for the work that you do. Any questions or comments on what Rina said? No? Happy to notice the report. Thank you very much, Rina. Urgent and emergency care reform, Jonathan.
Thank you. So one of the pressures and challenges of my role is that for the last 6 months I've been chairing something called the Urgent Emergency Care Task Force, which has had experts from across the system, some of them are sat in this room today, working together to understand how our emergency care system really works in Greater Manchester and what can we do to improve it. And we've now had an opportunity to bring all of that work together into this single set of proposals. The paper is in part diagnostic. It tells you what's not working with the system at the present time. Some of those are factors that are to some extent beyond our control in terms of sort of national, economic and social and demographic phenomena. But actually there's a lot that is within our control that if we actually made changes could enable our urgent emergency care system to work a lot better than it does today. And we see all sorts of benefits for patients, but also actually for the workforce if we were able to make these changes. In terms of the context, you can boil this down in terms of diagnosis really to 2 things. The first is that our system at the present time is over-reactive. In other words, it goes along within its own sort of localities, within individual institutions, until the pressure starts to mount, and then it very quickly moves into more of a crisis mode, at which point we move into more of a sort of command mentality in terms of sorting the problem out, getting ambulances back on the road, freeing up beds, whatever it might be. But it isn't a good way, really, to run a system in Greater Manchester as a whole. We would be far better if we were proactive, made far more use of predictive analytics to understand where issues are likely to arise and to plan accordingly in terms of our provision, both within hospitals but also out in the community as well. And we think we can do that. The second is we're too siloed. So we're siloed in institutions, are also too siloed in localities, when in reality our urgent emergency care system works as a whole across Greater Manchester, and lots of different institutions have got critical roles to play if the system as a whole is to make sense and to operate optimally. So in terms of the proposals which are set out in section 3, I'm only going to summarise these. First of all, about sorting out the governance. Our governance is confusing, and we propose establishing one board through which all our work on urgent emergency care reform is rooted, including the regional and national programme interest, rather than them having a tendency to parachute in to individual institutions and localities to do a particular piece of work. We need one coordinating mechanism. The second is we need a team to lead this. And I'm very pleased that NHS Improvement have not only agreed that there should be a joint team, but have actually nominated one of the leading experts in the country, an individual called Steve Christian, who happens to be based in Manchester, to lead that work, and have liberated some of his time to enable that to happen, which I think is very good news for us. The third is that we want to enable us to take a more proactive approach to operations by creating, for a couple of years pilot, a single 24/7 operational hub that would be co-located with NWAS and would enable us to have an ongoing dialogue with localities, with individual institutions, including NWAS themselves, about how we should be deploying resource at any given time, and also increasing the use of mutual aid between organisations as well. We've got a lot of work to do on informatics that will underpin our ability to flex capacity in real time. We've got a lot to do on workforce, particularly in terms of our work on filling hard-to-fill positions, including A&E middle grade doctors, nursing, and a number of other key professionals in working diagnostics as well. We've got work to do around our new models in the community, so we're doing a deep dive to look at the out-of-hours provision in each of our localities to make sure that not only does it make sense within that locality, but we understand the interfaces with, for example, neighbouring localities as well. As we take responsibility for commissioning of NWAS from tomorrow, so we need now to have a dialogue with ourselves and them about what does that mean in the way that we want to influence how both assessment and transport services work in Greater Manchester. And we know that there is scope for improvement. And then finally, and perhaps critically, if we get this right, what it should amount to is a new deal with the public, that we create alternatives to A&E that are reliable and which are clear in terms of how you access them, and then we communicate that very clearly to the public, for example, through the use of apps, so that it's very easy to know what the alternatives are. And the deal then is, please don't come to A&E unnecessarily, because A&E is, for what it says on the tin, accident and emergency. If we do that, we will reap a whole set of benefits in terms of patient outcomes by ensuring that patients are being treated in the place which is most appropriate and can be of most help to them. So I commend the paper to you and ask for your support so we can move this quickly into a delivery plan.
Okay, thanks, John. Any questions, comments on that? Darren?
So just a comment really, to welcome the paper. Linking it back to the Icon Health Innovation Manchester, one of the other things that we
to approve the establishment of the delivery board, approve the focus in the areas of work outlined, and approve the development of the detailed delivery plan. Thank you very much. Transformation theme 1, the public health system reform. Angela.
Thank you. So I'm delighted to bring this report today. This report builds on the GM ambition and shared commitment to place population health right at the heart of our public sector reform and economic growth agenda. It brings forward quite a detailed proposition. It's a long report, but we've got a summary that covers off the key strands within that. But it brings forward a proposition and a direction of travel that will really strengthen and further develop our approach towards creating a unified population health system for Greater Manchester. And this means a system that maximises not only the skills of the public health workforce, but has a wider cross-cutting focus, where population health is really embedded into our core business and everything that we do. Collaboration across a range of sectors and partnerships will of course be firmly at the heart of this approach and has already been so, and that's been very integral to support and drive the implementation of the population health plan, assuring leadership and focusing the effort and energy to achieve that radical upgrade in population health that we aspire towards. The work described has evolved over a significant number of months and has involved a broad range of stakeholders. Many of you are in the room today, and the engagement and the involvement will continue to grow as we start to take the work forward from today onwards. And through that involvement and engagement, I think we're bringing forward quite a detailed report with a range of insight and feedback, and utilising that, we've been able to translate that into a set of high-level proposals that will enable progress towards that unified system. The priorities for transforming the system are underpinned by the principles set out in the GM Commissioning Reform Strategy and are aligned with the Commissioning Review which is underway. And I think it's important just to think about what the impact of this system reform would look like for us and why it's critical that we drive this forward. As a result of the reform, I think we will see a stronger commitment to a reduction in unwanted variation in standards and population health outcomes. We will have an integrated population health system leadership actively working and joining up conversations across children's, adults and the wider public sector workforce. We'll also see accountability and leadership for population health that will be widely spread rather than seeing that in kind of silos or within individual organisations. So it won't be concentrated within single organisations, but it will be enabled also through our place-based approaches systems of care. Also, GM will be positioned to maximise, I think, the existing skill set, expertise and capacity that we've already got within our system towards delivering that GM ambition for a radical upgrade in population health. We'll also see more investment in wider community, voluntary and business sector infrastructure as part of a reformed delivery system for Greater Manchester, making better use of the wider public sector workforce as well. And by working with local communities and voluntary sector, our emerging local care organisations will provide a really important platform for implementing new and innovative models of care and prevention programmes which will improve population health and well-being. This will all take us towards GM creating a platform for further devolution, I would suggest, and that will enable us to ask central government to enable GM to have more control and develop key levers for securing population health gain, including, for example, through things like regulation for pricing mechanisms and improvements for environmental quality, so broadening the ask and opportunity that we have through devolution. And finally, the report describes the next steps and early programmes of work that we need to start So in bringing the report today, I'm asking the board to approve the proposals outlined in the paper and also acknowledge that a detailed mobilisation plan will need to be developed going forward. But the expectation is that will be completed by June. Thank you.
Joe Joy? Any questions, comments on this important work? No? So, can we read the recommendations? Mobilisation sounds like 1914 or okay, thank you. Transformation theme 4, hospital pharmacy transformation programme, Steve.
Thanks very much, Chair. So I'm pleased to introduce this report, which is an update on the hospital pharmacy transformation programme. The programme is one of the clinical work streams within Theme 4, and it's an area, it's a timely update because I think it's an area that's really starting to tackle some tangible priority areas around hospital pharmacy. So I'll hand over to Gareth Adams, who's the programme manager for the work, and he'll take just a couple of the key highlights and a recommendation for the board's approval on the Your Medicines programme.
Thanks very much, Steve. My name is Gareth Adams. I'm the programme manager for the hospital pharmacy review within Destination Theme 4. And I guess the purpose of today's report is to inform the board. So the purpose of today's report is to inform the board how the Hospital Pharmacy Collaborative are responding to ambitious locality plans and national drivers from NHS improvement, and also to brief the board on the Your Medicines Matter campaign. Today's recommendations are to note the Hospital Pharmacy Transformation Programme, to support the Hospital Pharmacy Review which is unfolding, and also to support the Your Medicines Matter campaign. Hospital Pharmacy Transformation Collaborative has been established for over 12 months, and our membership consists of provider chief pharmacists from across the region, focused by Lord Carter's hospital pharmacy recommendations, and the collaborative is challenged with overseeing and delivering transformation of hospital pharmacy services across Greater Manchester. Today's the deadline for Acute Trust have submitted their pharmacy transformation plans to NHS improvement, detailing how they intend to respond to recommendations within the Carter report. For information, the Greater Manchester submission accompanies this report. A key recommendation from Lord Carter is to enhance the pharmacy resource into clinical patient-facing medicines optimisation roles, specifying that by 2020 at least 80% of our activity needs to be devoted to these duties. Currently, given that on a national basis we invest 55% of our activity into infrastructure roles, which is supplying, dispensing medication, education and training and advisory roles, we have a significant challenge ahead. Services, in particular infrastructure services, must be therefore reviewed and redesigned to enhance the service delivery and to yield the workforce efficiencies that we require to reinvest into these medicines optimisation roles. Just to talk you through two of the priority must-do reviews that are currently underway. We're scoping the supply, procurement and delivery of medication across Greater Manchester, and also reviewing aseptic production across the region, which is where RD medicines are prepared for administration. Through detailed data requests and analysis, we are starting to understand the opportunities that collaboration can bring, and within our 17-18 work plan, detailed scoping and service redesign is scheduled. The report's final recommendation is for the board to support our Your Medicines Matter campaign. This is a campaign which encourages to remind and support patients and carers to bring their regular medication into hospital when they are admitted. It's a campaign that allows all healthcare providers across Greater Manchester to have a shared focus on delivering a patient safety initiative, as well as helping to reduce the medicines wastage across the whole economy. And again, for information, this campaign plan covers the report. So I do hope I've been able to provide a brief introduction forward and within hospital pharmacies being formed. In the attached documents we provide additional information, and I'll be happy to take any questions.
Yep. Still off Thomas is away, very keep your opposition for it. Any questions or comments? No. If you go, can we read the recommendations for the proposal to establish a children's health and wellbeing board.
Yeah, we're definitely still on, so I will share. Thank you, Chair, for that. Julie Cheetham, the Associate Director for District Clinical Networks, is supporting this work. This really was to bring the paper today, really, which is around the terms of reference for the start of a Greater Manchester Children's Health and Wellbeing Board for Greater Manchester. And really to recognise that the issues that we are all facing around children across the whole of our system, and to make sure that as part of our taking charge document we're absolutely recognising 25% of our population is cared for under the health and healthcare system. So really within the setup of the children's board, what we want to do is ensure that both from the health side and the social care side that we are bringing those elements together and recognising across the whole system a place where those children's conversations can make sure that we're collecting them in a single point and sharing that across. What we don't want to do is duplicate existing work that is already happening in a number of groups. But what we want to do is ensure that there is a place to land those conversations and set the direction of travel. The terms of reference as they are currently are very in its infancy. It will emerge and change as we develop and ensure that the membership is correct. It is quite challenging to ensure that we've got all areas covered, but we will ensure that that does happen as we progress the agenda going forward. So that is really all we wanted to introduce today, but with the recommendations that we can take the board forward if colleagues are comfortable with that. Thank you.
Okay, thank you, Julie. Any questions? Darren?
Darren Banks, CMFT. So, well, to everything that Julie just introduced and presented. And I also welcome what you're saying about the terms of reference. I think there are other stakeholders who bring expertise and knowledge into the district around children's services. And equally, we have expertise and knowledge working at a national level within Greater Manchester through the Children's Alliance, which is also working on new elements of standards for children's health, which I think we can learn from within Greater Manchester. Final point is there's already reference in the membership proposed to themes 2 and 3, and we're currently recruiting to clinical leadership roles for the theme 3 for the prioritised areas, including pediatrics. In 3 weeks' time, we'll have an appointment to a clinical lead. I think would be a really significant addition to the membership as proposed.
Julie?
Gary, I think you're absolutely right. And what we really want to ensure that from our perspective we have got really, really strong leadership in there, and absolutely theme 3 clinical leads are part of this. It's documented at the minute around the transformation unit because we haven't got names in the frame, but absolutely we need to make sure it's clinically led.
So very happy with Darren's comments, which we'll take on board, and Julie's response. But I do want to make a point that there is something very deliberate in the way that the Children's Health and Wellbeing Board is set up to try to move away from what I think has been an over-acute hospital focus on children's health in Greater Manchester. And you can see it in the levels of hospitalisation of children for common conditions within Greater Manchester, which are very high for the most part. And so the main focus of this board needs to be on the prevention, early intervention, out-of-hospital pathways, and the joining up of our children's health objectives with broader economic and social objectives, including, crucially, tackling poverty.
Anyone else? meeting taking place soon, April 1. Thank you. Health and homelessness work.
Thank you, Chair. This paper is just a signal to identify to the board Greater Manchester's intention to develop some specific work around the homelessness strategy, and particularly identify the role and the contribution of the health and care sector to the design and implementation of that strategy. So, very early days, and an expectation that this work starts to come together as part of a broader package of housing and health work that I think starts to recognise where issues related to housing quality, housing security, the housing sector's connection to LCO development and the opportunities around housing with care ought to have a similar degree of kind of status and profile to the progress we've been able to make on the bringing to life the relationship between work and health. So there will be a broader package of housing and health work that will start to bring through the board's governance in the coming months. But we've recognised a particular urgency around homelessness that in terms of presentations with priority needs is now at its highest level for the last decade. There is a Greater Manchester model in development that is supported in part by some national opportunities for funding, focused in particular on rough sleeping and opportunities for homelessness prevention. And we're starting to test that through a description based on best practice from within Greater Manchester and elsewhere of the potential role of the health and care sector and the delivery of those homelessness prevention and response objectives. The proposal as it stands is that we do some focused work with colleagues from across the sector over the coming weeks and bring back a complete homelessness prevention strategy for the board's consideration in the coming months. So we're asking today for support for development and engagement on that work to develop that preventative strategy and the engagement of colleagues in the work to consider the health contribution to that strategy.
Okay, thank you, Warren. Tony?
Yeah, can I just actually want to very warmly welcome this report. So as people around the room may know, as Warren's indicated, a number of bits for the Greater Manchester work with one strong central government to operate at various levels in those issues of caused homelessness. But obviously, at the rough sleeper end in particular, we know that an input from health is absolutely fundamental. Providing a roof is necessary, clearly it is. But actually, if we don't begin to address the underlying causes that brought people into the rough sleeper category, then we're failing. Obviously, within this, very strongly welcome the paper, and Warren, I appreciate what has been said about this need now to be taken forward. But obviously, within that, all would ask the obvious question that mental health clearly has got to be totally embedded approach as well, of course, with alcohol and drug treatment services, because those are the things that will in the end make material difference to offering an alternative and better lifestyle.
Warren?
Only to agree. I think the paper outlines the start of the work really to understand some of the main causes and where some of the real touch points in relation to the connection to the health sector are, and I think it does highlight the kind of critical range of interventions around mental health, around discharge from hospital, and around the provision of primary care. And I think we've got some really good examples in Greater Manchester and other examples that we'll tap into nationally that will really start to give some definition to the scope of the role and contribution from those sectors.
Any further comments on the paper? Can we agree to recommendations? Thank you. Personalisation and choice in Greater Manchester. Steve, will you start?
Yeah, thanks. I'll just introduce this and then hand over to James Sanderson, who is the national lead within NHS England for personalisation and choice. The paper you've got sets out how we can take forward some of the techniques and the opportunities within that national programme and use them in Greater Manchester to support localities in providing in helping them deliver the care and personalised care around the needs of the people and the patients of Greater Manchester. So I strongly endorse this, and I'll do it in the words of Karen and Gav. So I hosted or co-chaired an event a couple of weeks ago on personalisation, which was a real privilege, and I co-hosted with Karen and Gav. Gav is an Oldham resident who has a number of conditions, including multiple sclerosis, and has been the recipient of a personal health budget for the last couple of years. And Karen, in Karen's words, quite starkly, Gavin would not be alive today if it weren't for the benefits of a personal health budget. So with that ringing in our ears, I'll hand over to James, who's going to talk a little bit about the programme.
Thank you, Steve, and thank you, Chair. Delighted to be here today. Thank you for the opportunity to present these proposals. As John mentioned at the beginning of the meeting, the delivery plan that's published today by the NHS makes quite a significant mention of the need for improvements in personalisation. It talks about the fact that the lack of integration between health and social care, between primary, community and hospitals within the system creates a barrier for personalisation. It talks about the need to really accelerate progress on integrating support around the needs of an individual. What we're finding across the region, across Greater Manchester and also nationally, is growing demand for personalisation in health and care. And with personal health budgets, we've actually experienced an increase of 174% of recipients of personal health budgets nationally over the past 15 months. I think there's also a growing recognition in the power of communities to plan and develop their own solutions for health and care, and the opportunity to unlock the renewable energy that comes from patients being empowered to take a more active role, and also in communities and the assets that communities can bring to health and social care. What we've got with the programmes that we've presented to you today, with integrated personal commissioning, personal health budgets and our patient choice programmes, is we've been creating a very clear delivery infrastructure that helps achieve personalisation at scale. The programmes that we've designed are not just about personal budgets, they're about creating community assets, creating peer support networks, creating the opportunity for much more effective person-centred care planning, local area coordination, self-care and some of the other ingredients that you would need within a system that's operating for the benefits of the patients and people that it's supporting. However, this is not a proposal that's about imposing a national system on Greater Manchester. We recognise completely that you've got a unique environment and there's a considerable amount of work already in place that meets and exceeds the expectations that we're establishing nationally for other areas. We also recognise that many of the features that we have implemented within these programmes have actually been pioneered in this area, and personal budgets in social care, for example, a lot of that was innovated in Greater Manchester, as you'll all be aware. So it's about building on existing work. It's about looking at what's already in place and providing a series of tools and methodologies that are complementary to the work that is being undertaken. But we think there's an ability to go further and faster than other parts of the country. We've identified a number of specific areas that we think would be priorities for the first phase, which is people with long-term conditions, people at the end of life, and for people with a learning disability, and also looking to improve overall choice and control for patients within the system, whether that's within elective care or community-based services. So the proposal is about bringing together our national resources and expertise that we've got in developing these programmes, together with the Greater Manchester Partnership, to look at ways of delivering improvements for patients and look at accelerating the priorities that you've already got. And we're seeking support today for the proposals and also the local leadership that will be required in order to implement the systems. Thank you.
Okay, thank you, James. Any questions and comments on that report? Sure, happy to note that and approve the next steps. Thank you. Working well, is it Matt?
Thank you. I know that you've all received a report and presentation, so I'll just pick on a few highlights which I think are particularly pertinent to this board. The Working Well pilot, which went live in 2014, has now worked with almost 5,000 people and supported 500 into work. Now, all of those individuals have got significant barriers to work, and the average length of time out of work is 6 years. However, some of the information that's now coming through some of our intelligence and econometrics shows that those people who start the programme and identify their physical or mental health as significant barriers to work are faring significantly less well than those who don't on the programme. So it appears that mental and physical health barriers are real critical barriers to work. So we do need to find a way collectively of joining the health and work system, both in terms of research, intelligence, education, advice and support, if we are really going to tackle that issue. Now, we've expanded the original pilot to a further 10,500 people, and we've started to test some areas where the health and work system could work together more collaboratively. And one of the things that we've tested are around gateways and signposting to support. So on the Working Well pilot, all of the referrals onto the programme came via the job centre. On the expansion, we've opened that pathway to GPs. And one thing that's really interesting is that for those people who are referred onto support by the job centre advisor, the take-up rate is 60%. For those who are referred or signposted by their GP, their take-up rate is 77%. So it appears as though that trusted relationship between patient and GP is really making a difference. So there's something about that kind of key messaging of work through the health system that could make a real difference. Another thing that we've tested is embedding talking therapists, so IAP support within the Working Well delivery model. And again, that's shown some quite interesting findings to date. A number of things that have come out, one of which is our talking therapist provider has said many of the people that have been referred to them, although they've got long-term mild to moderate mental health conditions, don't appear to have any engagement with mainstream mental health services. And secondly, they are accepting people who they said wouldn't ordinarily get through their kind of thresholds for IAP support because they're too complex. However, 68% of those who have been referred are entering treatment, and the reliable improvement is 73%, with recovery rates of 53%. So it appears that joint working, the flexibility first of all in terms of their acceptance onto the programme, and the joint working between their Working Well key worker and their talking therapist is improving outcomes for the IAP service. Now, these are still early days, but the initial findings are quite positive. Now, for us, these are just some quite early learning. What we're really keen to do is see how we can develop a more transformational employment and health system that isn't just working at that acute end, so supporting those who are long-term unemployed, but what can we do more collaboratively to create more healthy workplaces, to keep people healthy at work and increase productivity, but right the way through to the other end of improving or reducing the disability employment rate gap and creating integrated Greater Manchester pathways into work, for example, through the £53 million devolved work and health programme. So with the board's support, we'd like to come at a future date with some more detail about what is, I believe, a kind of transformational five-point plan for Greater Manchester around work and health. So if the board's supportive, that's what we would like. Thank you.
Thank you, Matt. Any comments? Again, really important piece of work, so thank you for that. Can we agree? Thank you. And now we come to a presentation from Stuart.
Thank you, Chair. This very important but very short presentation is going to be presented by three of us, Chair. Claire Holding, who's here, who's our partner in adult safeguarding for CCG, Stuart North, who's the Chief Operating Officer for the CCG, and myself, who's interim Chief Executive of Bury Council. And our presentation is talking about the importance of working together across a health and social care with residential care homes. In the council, we've had a quality assurance process in place for many years. And that's working in collaboration with the social care providers, including homes. So this is domiciliary support. So if everybody you. Thank you very much. Somebody heard. Thank you very much. As I said, this is a supportive process. We're not a regulatory. We don't go in as a regulatory arm. We go as a supportive process. We celebrate the success in the homes. We also, where homes need more assistance, we work with them very effectively with the team. We have good quality residential nursing care in Bury. Over 80% of the beds are rated good by CQC. The market is stable within Bury. We are now working very effectively to improve our EMI range of facilities for people. So that's my part of the presentation, Chair, so I'd like to hand over to Stuart.
Thank you, Pat. Are either good or even outstanding. And the residential homes, it's a small proportion that require improvement, and we don't have any homes that are classified as inadequate. Why does this matter? Well, it's not just about the quality of care, but it impacts on outcomes. Bury has the lowest rate of admissions for people over 65 in Greater Manchester, and the lowest rate of readmissions. And this is one of the contributing factors, is the resilience of the care home sector. I'm going to pass over to Claire Holder, who is going to describe in detail the proactive approach that we adopt with our care homes and residential homes to develop them.
Okay, so starting really at the beginning of coming into post 4 years ago was looking at our very isolated, unsupported, registered nurses out there in nursing home land. Very difficult to recruit nurses nationally, we all know that, and very difficult to retain them. And when you haven't got the backup of the NHS terms and conditions, it's even more difficult. So how can we help these home providers? So we started having a safeguarding and quality forum led by myself, chaired by myself, with colleagues from local authority in attendance. A slow burn, but now people are knocking on the door to become members. It's a two-way process there where we're giving information and we're receiving information and receiving their input around what support they feel they need to improve further. The joint assurance visits, as we've already discussed via Pat, we joined as a CCG with our local authority colleagues to complete safeguarding assurance visits. So instead of visiting our homes to death, we went once and we assessed them once, and they found that very supportive rather than punitive. Following those inspections, we have regular keep in touch visits, which again are purely around support and helping with the resilience. The additional health input from the CCG in this area does at the moment focus around the nursing home sector. We have a clinical supervision pilot underway at the moment. All nurses now have to revalidate as clinicians. If you're not managed by another nurse, you haven't got the opportunity that's required within the revalidation process to achieve your revalidation. So how could we help those nurses do that? So as a CCG, we're now the supervisors, the clinical supervisors for those nurses. We offer a network of support. We learn from each other. We have peer reviews. That pilot will be written up in May following the 12-month process, but it is foreseen that it will continue. We facilitate the networking within homes. Some homes have got some really great work going on, and although they're seen as the Cinderella service of nursing, actually we need to give them some support and recognition of the good work that they're doing. We've recently had one of our nursing home leads published in the Nursing Times around some great work regarding medication errors. At the moment, we've just started the React to Red initiative in Bury. It's something that is, can we just forward, sorry, to the next slide. It's something that is a national initiative, and all my colleagues across Greater Manchester as adult safeguarding leads have received this from NHS England. But people have decided to facilitate it in different ways. In Bury, how we've decided is to work with our already integrated partners, and we had a big launch with Pennine Care and with our local authority colleagues. It was well supported and they were well engaged. We've delivered our first cohort of training to 20 of our homes. It involved a half-day training session facilitated by myself. We assessed the competencies of the carers that came to the session. They're now going off to cascade that training within their own organisations. And again, that extends to domiciliary care organisations. We don't want to just do training and then leave people out there. So we've got an ongoing support network. 3 times a year we'll be offering formal support for these carers who are carrying on the work of cascading the training. The aim is to capture in Bury all of the care homes and providers and reduce the incidence of pressure ulcers. The clue's in the name, react to red. So if we move to the next slide, I know you won't want to see it for very long. The first part is a red area on a patient's skin. The second part is how it quickly develops. And this is usually at the point where it becomes a causative factor during somebody's inquest via the coroner, and you can end up with a Regulation 28 about preventing further deaths. It's a massive piece of work to do, but the message is that's avoidable. So can we move on? So the impact of pressure ulcers is, first of all, we should be looking at our patients, our residents, and it causes distress. It causes pain, infection and low self-esteem, and surely that should be our priority. For care workers, it increases their workload and demands on their time. For the organisations, there's a financial burden and a reputation risk. And actually, to the public purse, pressure ulcers cost the NHS between £1.4 and £2.1 billion a year. It's a massive implication for prescribing here as well. But the point of the exercise is it's avoidable, and React to Red will go some way to helping us achieve that avoidability. Across the country where it has been implemented, there has seen a significant reduction in the numbers of pressure ulcers. So just in summary really, I feel that it's a passion of mine, as I'm sure you can tell, that we need to offer some resilience and support with retention of nursing staff in our care homes. They're a massively important sector. They haven't come into this business to harm patients, but they need the support of everybody really as an integrated care organisation to help with that. Thank you.
And just as a final comment from myself, but I struggle to summarise it better than Claire did with her passion there. But I think it's an important thing to recognise that the care home sector gets a bad press. But actually the vast majority of people who work in the care home sector want to do the right thing for the residents. If we provide them with the right tools and support, and it doesn't cost a lot of money to do that, it's just the right approach, we can facilitate them to deliver the right care. Thank you.
Okay, thank you for the presentation. I'm sure it'll be memorable for most people. Thanks for the photograph. So well done, Barry. Dates of next meetings are on the paper. Can we note those? And the report of the GM Transformation Portfolio Board, which again is ready for noting. So I think at this point we come to... Sorry.
Neil Turner, Wrightington, Wigan and Lee. Can I just refer to 333 and the third bullet point, which talks about public engagement and consultation. We've got to remember that we're not, although we have organisations which are democratic, we're not ourselves democratic. And we're talking jargon and acronyms, and it's very difficult for ordinary people to get into this and understand what we're talking about. And I think we need to do that, because if we don't explain to people what we're doing, why we're doing it, what the decisions we're making and the reasons behind that, then it creates a vacuum for all sorts of people to come in and say all sorts of daft things around. So I'm just wondering, I'll put it back to you, Chair, whether or not we should have some kind of a PR system where after these meetings we have a press conference where the important issues that we've decided are actually put in such a way that they can be presented to the Manchester Evening News, the local press, radio, etc., in a way that people can be able to understand them.
First of all, you're absolutely right, so thank you for that. We do produce exactly what you've just suggested, which is basically a summarised, jargon-free press briefing of all the key papers, and we put it out actually a day or two before the meeting, and we do get pickup, which gets translated into articles both in Manchester Evening News, also radio interest, regional TV we've had on one occasion. We've been a bit more restricted this time because of the pre-election period, but normally that is exactly what we do. It makes me wonder though, I think what we should do is actually put out that briefing around the board. Yep. So I think so everybody else has got it as well, because you might find it useful as a synopsis and also when you're talking to other people.
I think we do put a note out after the board meetings for board members, but maybe before would be helpful too. Okay, well that's the end of the formal agenda, but there is one other important matter of business. It's the final meeting today of someone without whom we wouldn't actually be meeting here at all today. If it hadn't been for Sir Howard Bernstein, his skills of negotiation, his intellectual talents to persuade NHS England that they ought to give health devolution to Greater Manchester, what, 2 years ago now, Howard, I think we wouldn't be here today. We wouldn't be able to have all those interesting and exciting papers that we've dealt with earlier today. And Howard, I think, always saw this not just about improving health and health inequalities. So I think the stuff that Matt came through, he saw that as the importance about creating more jobs in Greater Manchester. If we get people healthier, then we get them back into work. And of course, the exciting stuff that Rowena's involved with, again, Howard saw that as one of the long-term things that we could benefit from that. And let's never forget, of course, that not only did he negotiate devolution, he got a transformation fund of £450 million, which is the envy of any other part of the country, because when we do make the plans, we know that we need to change, we all need to change as organisations to become more effective, then we have the money to support it. So Howard, on behalf of everyone on the board, thank you for what you've done. My wife says she's still not forgiven you for persuading me to become the chair. But, you know, it's been a terrific trial. And even the last paper on, you know, React to Red, I thought you thought was a football analogy, I think. So, on behalf of the board and also the people of Greater Manchester, Howard, a little something for you that I'd like to take as a memento. See you at 11:45.